So, good night, everyone, and welcome back to our OCMO weekly Wednesday gynecology didactics. And tonight is the second day and the last day of our gestational trophoblastic disease module. Last week, we have an overview of management of gestational trophoblastic diseases with Dr. Muhammad Anwar. And tonight, we have really the honor to have one of the most eminent new stars, rising stars in the pathology, in the world of gynepathology and surgical oncology pathology in Egypt, Dr. Dina Saman. More or less, she is now very well known for most of surgical oncologists and gynecologists in Egypt and even pathologists. Dina is very active in delivering educational material and in delivering a very high standard presentations and high quality presentations about pathology, and is real an addition for all the teams that work with her. Dr. Dina Saman is lecturer and consultant of pathology from Ain Shams University. Welcome, Dina, and the floor of you, and thank you for your time. She's going to speak tonight about gestational trophoblastic disease, and for our 50 participants, if you have any questions, just write it in the Q&A box, or you can discuss it after Dina finish, and thank you.
Good evening, everyone. This is Dina Samain. I'll be talking to you today about the pathology of gestational trophoblastic diseases. But firstly, let me express my deepest gratitude to my dearest Professor Basel for his introduction to me and for his very kind invitation for me to be with you tonight. I'm always excited to contribute with him scientifically, actually. Okay, so this was your long day after many surgeries. Maybe that's the end of your day, or maybe that's afterwards. Okay, so now let's try to enjoy a little what we will be learning today. According to the WHO, the fifth edition, the female genital tumors, gestational trophoblastic diseases are classified into molar pregnancies, which are furtherly classified into complete hydatidiform mole, partial mole, and invasive mole. The second category or class is the non-neoplastic lesions, and these include the exaggerated placental site and the placental site nodule or plaque. The third class is the GTN or the gestational trophoblastic neoplasms, and these include the choriocarcinoma, the epithelioid trophoblastic tumors, and the placental site trophoblastic tumors, and finally the mixed trophoblastic tumors. And finally, we have the category of abnormal non-molar villus lesions. Okay, but firstly, let me ask actually two questions. Maybe ask myself and ask you too. Why do we call them gestational, and why do we call them trophoblastic? Actually, gestational because the diseases we'll be talking about today are either a gestation in themselves, or they come after or with an antecedent gestation. So, what's gestation? I believe that you know better than me that gestation includes pregnancy that might be normal, abortion that may be spontaneous or induced. It includes even ectopic pregnancy and the molar pregnancy that we will be discussing tonight. But why are called trophoblastic? Okay, now let me take you through a quick journey back in time. Back in the womb or the uterus of our mommies, when you were a blastocyst, then an embryoblast, and you had that trophoblast layer, that layer surrounding you and us, okay, of the cells that are called the trophoblasts. Trophoblasts are actually the cells that are incorporated into the formation of the chorion, that has those chorionic villi that implant into the decidua to form the placenta. The placenta, that is the actual channel for the exchange of the nutrients and the gases between the mom and the baby. Okay, so trophoblasts are classified furtherly into three histological subtypes. We have the cytotrophoblast, the syncytial trophoblast, and the intermediate trophoblast. The cytotrophoblasts are actually the stem cells. These are cells that are capable of differentiating into the syncytial trophoblasts and the intermediate trophoblasts afterwards. They do not secrete anything, so no hormones, so they give negative results with immunohistochemistry. Maybe they're only positive for cytokeratin, but they have a high proliferative power, as that I've just mentioned. They're the stem cells. So the proliferative marker, immunohistochemical marker that we call the Ki67, may give a 25 to 50% expression. What about the syncytial trophoblasts? These are the cells you probably remember from your late studying days. Those are the multinucleated cells They're capable of secreting a number of placental hormones actually, and they are responsible for the exchange of the nutrients and stuff across the placenta. They do not have a high proliferative power, so in normal conditions the Ki67 is actually negative. What about the intermediate trophoblasts? These cells, or these guys, are the ones that are supposed to be responsible for the invasion of the placenta. They actually have three categories or three subtypes according to their location. So the chorionic type are the ones in the chorion levi. Okay, and the villus types are the ones at the around the villi, and the implantation in intermediate trophoblasts are the ones that actually invade into the decidua and play a major role in the remodeling of the maternal vessels and establishment of this placenta formation. Okay, we call actually the implantation intermediate trophoblast is extravillus trophoblast together with the chorionic, whereas the villus, the cyto, and the syncytial, these are the villus trophoblasts. Okay, as you can see here, this is the chorionic villi. They're formed at the fetal blood vessels inside, lined by the cytotrophoblast and the syncytial trophoblasts. That's the maternal decidua, and those are the extravillus trophoblasts trying to invade into the maternal decidua and into the maternal bloods for remodeling. So why are you telling us all these histological details, and how would this have actually a clinical application to us clinicians? Yes, this would have a clinical application because all the GTDs that we'll be talking about today actually originate from those different types of trophoblasts. So what's then? How can we benefit from this? If we know that each type of those trophoblasts actually is expressing, I mean, a number of immunohistochemical stains, then we can use immunohistochemistry to identify this type of trophoblast and accordingly identify the disease that we are suspecting or in our case. The syncytial, for example, they express HCG, the implantation site. For example, they express the HPL and the MELCAM. The chorionic express the P63, and the cytotrophoblast express the cytokeratins. Okay. What about the molecular? Yes, this is one more thing. As we dig deeper into the different types of diseases, we will learn later on that some diseases are formed of maternal and paternal chromosomes only. Some others are formed actually with the somatic maternal only. Okay, but these are not actually GTDs. They will be out of the differential diagnosis, including, for example, somatic carcinomas with trophoblasts. Now we will learn how to differentiate between them afterwards, and molecular would actually play a very important role in differentiating in the different types of GTDs themselves. Okay, firstly, let's begin with the molar pregnancy. But before going so much deep into each and every type, let me make you some introduction about pregnancy. So what happens actually in pregnancy generally? We have the normal case scenario when we have a single sperm fertilizing an ovum. So there's a paternal genetic material together with a maternal genetic material. They both give a biparental, meaning from both parents. Diploidy means two sets of chromosomes, and this is what happens actually in normal pregnancy. What about the partial mole case scenario? In partial mole case scenario, you have actually two scenarios. The first one is we have two sperms fertilizing a single ovum, two paternal genetic material, one maternal genetic material, resulting in a triploidy that is diandric with two sets of paternal chromosomes. The second scenario is the fertilization with a single sperm that the genetic material becomes duplicated afterwards to give a diandric triploidy. Actually, you have a third case scenario that is reported in some papers, which is the triandric tetraploidy, where three sperms fertilize an ovum and we have three sets of paternal chromosomes, or maybe because after duplication, and the tetraploid you have four sets of chromosomes all in all. Okay, now what's actually the case scenario that occurs in a complete mole? We have three case scenarios. The first one is the fertilization with two sperms in an ovum that has lost its maternal genetic material either before fertilization or after fertilization, resulting in a diploidy that is diandric, two 2-endric diploidy. Okay, the second case scenario is we have a single sperm fertilizing an ovum, then the duplication of the paternal chromosomal material. Again, this ovum has lost the maternal genetic material either before or after the fertilization. We have again a diendric diploidy. The third case scenario, and this is the rarest one, that we have a single sperm fertilizing an ovum, that the maternal genetic material is there and the paternal is still there, so we have a biparental diploidy. So what's the problem in that? The problem is actually there's a mutation in one of both those genes, the NLRP7 or the KHDC3L. These genes, when they are muted, it's like they silence the expression of the maternal genome. So we have a maternal genetic material, but it's unexpressed. It's as if it's not there. So this again results in complete mole. The last key scenario that I chose to mention today as an example between all these is actually the digynic monoandric triploidy. This is not an example of a GTD, but it comes within the differential diagnosis of GTDs. Okay, we have a single sperm and a single ovum, and with duplication of the maternal material, so we have a triploidy 1, 2, 3, two from the mother, so they are called digynic, and one from the father, that's monoandric, and this is a triploid. Okay, now we'll be going through the different types of GTDs in the form of case scenarios, okay, to explore each and every type. Case 1, we have a 33-year-old woman who has 11 weeks of amenorrhea. She had her pregnancy test and was found to have those two pink lines. She was happy afterwards until she got a vaginal bleeding, and when she went to her obstetrician so fast and he ordered her the beta HCG. Beta HCG was actually elevated, very highly elevated. This is 250 kMIU per milli. Then she had her ultrasound, and look what we have seen. Well, she has this thing. What's this? They call it in ultrasound the snowstorm appearance, those multiple cysts. Okay, furthermore, she didn't have any fetal parts, no fetal heartbeats, no fetal pole, nothing. Okay, so they had to take a decision for the dilatation and evacuation, and we had this product. Yeah, if you can notice, there's some things that are like vesicles or like grapes or something like this. Okay, so under the microscope, we had this picture of dilated villi that were hydropic. Again, they had actually trophoblastic proliferations. The whole slide looked like this. We'll be seeing this. Then we had a new kit for the IHC P57. We thought, why don't we try it? The P57 gave us negative results actually in the cytotrophoblasts that are lining the villi and in the stromal cells in between, except for the positive internal control. Okay, and finally, somebody was passing by from the molecular unit and told us, why don't you make her some short tandem repeat sequencing? We did this and we had a bipaternal dispermic diploid. So after all this, what were you suspecting, or what we should have been thinking of? Yes, definitely a complete hydatidiform mole. But let me tell you at first that what does this word or term come from? In Greek, hydatesia means water drop. And as we will be seeing in the gross picture, yes, the tissue looks like water drops or grapes. And mole means false conception. Yes, this is for sure false conception. This is not a true conception that will result in a baby, actually. Okay. As for the diagnosis of the hydatidiform mole, there's one nice diagnostic pathway proposed by the European Organization of the Treatment of Trophoblastic Diseases. You'd rather go back and check this, and they have the minimal requirements for diagnosis and the best practice for diagnosis. We have almost gone through the minimal requirements through our cases. Don't forget to check those best practice for you all clinicians. Okay, so what's the definition of a complete mole? The complete mole is an abnormal gestation that is characterized by diffuse trophoblastic proliferation, and thanks God we all know what's trophoblastic proliferation now after we have reminded ourselves what are the trophoblasts. Okay, it's characterized by the presence of the villus hydrops, that's the villi that are full of water or distended with hydropic material, and it's diffuse in the complete mole actually. What's really characteristic is we do not have any embryonic development. And for the genetic imprint, we have only paternal, only androgenetic diploid material. This actually can occur in the uterus and thus commonly in the ectopic sites. What about the epidemiology of both modes, the complete and the partial? They're more common in countries like those in the Eastern Asia, the Middle East, and the South America, so we are included. They're least in the Western Europe and the North America. What about the risk factors? As for only the complete mole, the extremes of age, maybe less than 20 and more than 40, are considered as risk factors. The history of prior mole is another risk factor. And finally, the genetics, okay, that we have seen in the familial one complete mole. So what else would my patient be complaining of except for vaginal bleeding? Actually, your patient might be symptomatic, and you might spot her with her routine first trimester ultrasound and diagnose her earlier when you cannot find any fetal pole or any fetal parts or anything, okay? But let me frank with you, in the very early things are not so classic actually in the ultrasound or in the pathology, but at least you will suspect and you will find her on the follow-up together with beta hcg in the ultrasound, okay? She might come complaining of vaginal bleeding, excessive uterine size, hyperemesis, ovarian thecal lutein cysts, hyperthyroidism, and maybe preeclampsia owing to the very high hcg level, which are more than 100 kmiu per milli. And this is her ultrasound, we've seen it before. What about the pathogenesis? The same thing that we have explained in the very first map of pregnancy. This is one of those scenarios. We have a sperm that fertilized an ovum that lost the maternal genetic material either before fertilization or after fertilization, and this single sperm duplicated, giving 23x and 23x. So we had the 46xx. That's why they call this the monospermic complete mole. And it's homozygous because it comes from only a single sperm, and these are actually majority. The second case scenario, that we have two sperms fertilizing the ovum that lost the maternal genetic material either before or after fertilization. Then we have again a 46 that might be actually an XX or an XY, but at the end of the day, it's dispermic because it came from actually two sperms, and this is less in incidence. The last form is a single sperm that fertilizes a single ovum that has one of those two genetic mutations that result in a failure to establish the maternal imprint and actually resulted in 46XX, but this is not a human being, that's a diploid biparental complete high TD4 mole, and this is actually extremely rare and familial at the same time. So how are we going to see this on a gross picture? On a gross picture, again, if it's really early, it would look like a regular product of conception, maybe just bloody tissue pieces. But as the time goes on, that the tissue progresses, it start to give us this hydropic like villi or grape like shape maybe. Those ones are suspended in saline, that's why they look beautifully like water drops or like grapes, okay? And we agree that we do not see fetal parts, except maybe on one condition. There's one condition that when we can see fetal parts, and this is actually an interesting thing. If we have twins, yes, if you have twins, sometimes if you have a twin that is one of them is just a fetus and the other one is a complete mole, and then you get the abortus and you start thinking, is this a partial mole or something? Okay, then it's actually a complete mole, but it was a twin. Okay, so that's again one of the differential diagnoses or the diagnostic dilemma that we go through, and I'll tell you how can we deal with this when we reach the partial mole. What about the microscopic picture? We have actually enlarged hydropic villi with frequent cisterns. I say to my pathology residents, cisterns are the pale edematous areas in the middle uh, of the villi that are almost acellular. In the complete mole, we do not see blood vessels actually or fetal RBCs because there's no fetal parts, so they are just avascular. The trophoblastic proliferation are marked and they are almost circumferential, or they are actually circumferential. We see significant atypia in areas, and this is okay, especially the implantation site. You shouldn't panic if you see an implantation site with atypia in trophoblasts. Okay, there's no fetal parts, as we agreed. There's even no non-villous placental parts. Okay, we have only those villi. Sometimes the syncytial trophoblasts, they make this medusa-like head. Okay, but again, let me be frank with you that in the very early, the villi may not be as enlarged in this, they may not be as classic as this, and we may need to use an immunohistochemical stain, that is the P57. The P57 is actually a very nice stain that is actually absent in the complete mole in the cytotrophoblast, those cells lining the villi, and the stromal cells that are inside, or at least they are less than 10% expression to say that this is a complete mole in sporadic and both sporadic and familial bipaternal cases. Okay. Let me tell you the story of the P57 in brief, because actually the P57 is a stain that we can use to differentiate between complete mole and the mimics, including the partial hydatid deformed mole and the other non-molar gestations. And why the P57? Because the P57 actually, it is a gene that is paternally imprinted and maternally expressed. Okay, so if we have a product like the complete mold that is only carries only paternal genomes, then we have the gene, but it will never ever be expressed as long as we do not have the maternal genes. You know that males are very strong creatures. Actually, they can do anything in life without females except for one thing, which is the expression actually of the P57. So they need maternal genes. Okay, so we can use this fact that we do not have an express gene, so we definitely do not have a protein. So if I have an immunohistochemical stain that stains this protein and this protein is absent, it will give us a negative result. And this is actually what occurs in the complete mole. In contrast to the partial mole and other molar pregnancies where there is a genetic material of the mother, the maternal and the paternal, so the protein is expressed and the immunohistochemical stain is positive. And this is really beneficial, especially in early cases where the histological picture is not very like clear and vibrant. And that's again a nice hierarchy to use if you are suspecting what do we have to have a complete mole or partial or non-molar, and you want to begin with a P57. So it's negative, you go for the complete. If it's positive, you can go for the molecular genotyping to see what you have got. Okay, so what about the differential diagnosis? We have the complete mole versus the partial mole versus the hydropic abortus versus the non-molar early gestation that may overlap with morphology with the villus hydros and trophoblastic hyperplasia. But we can differentiate all these versus the complete mole using the P57. And finally, there's the diagnostic molecular testing using the short tandem repeat genotyping or sequencing that will give you an androgenetic only genome with absent maternal DNA. Some people may opt for maybe karyotyping or something like this, but actually karyotyping provides you with a number of ploidy only. It says it's diploid, it's triploid, it's tetraploid, but it's incapable of giving you information about whether it's paternal or maternal. So if this is available, this would give you a precise diagnosis, especially for sporadic that are androgenetic only, complete moles. To wrap up things, according to the WHO, we have essential criteria and desirable criteria. Essential criteria include the morphological or the histological features with the P57 in early cases. The desirable are the genotypic analysis. Now, what about the prognosis? We have like 15 to 20% would turn into persistent GTD, and this occurs actually in the heterozygous types more than the homozygous types. So 2 to 3% will give rise to choriocarcinoma, and we have 1% would result in recurrence. And this sheds the light actually on the importance of the HCG surveillance in those case. Let's go to case 2. We have got a 28-year-old female with 14 weeks of amenorrhea. Now she had vaginal bleeding and a pregnancy test. Sorry, she had firstly a pregnancy test with two nice pink lines. Note these lines are not always nice. They're sometimes catastrophic actually. Okay, then she had the vaginal bleeding. She went for beta HCG blood test and it was found to be only 7K. On ultrasound, she had cystic changes, but actually they were minor cystic changes in the placenta, and she had this is the fetal part. Okay, and owing to her vaginal bleeding, and then they had to take her decision of to dilatation evacuation, and we had this. Okay, this part actually the product of conception in this fetus. Let me be some sort of frank with you. This is not always the classic picture. We in most of the cases we do not get this, so things are not so clear. And then under the microscope we had those trophoblastic villi. We had actually two populations, the dilated, the pale ones, and the fibrotic, smaller ones. We had the P57, it was actually retained in the cytotrophoblast and in the stromal cells. And finally, somebody was passing by and told us that we have to do actually molecular testing in this case, and it was found to be the diandric monogynic triploidy actually. So what were you thinking of, or what did you suspect? Yes, actually, this is a partial hydatidiform mole. Again, this is the same diagnostic pathway for the European Organization of Trophoblastic diseases. Okay, go back to please, refer back to please. And what about the definition, the partial mole? Again, partial mole is an abnormal gestation that is composed of trophoblastic proliferation with a villus hydrops, but this part, the hydrops, is only involving part of the chorionic villi. Now we have sort of embryonic development, and as for the molecular or the genetics, we have a diandric monogynic triploid, and this is really fundamental in most of the cases. Okay, so what about the clinical presentation? The most of the cases are presenting with missed or incomplete abortion, the late first or the second early trimester. She will might probably come to you with vaginal bleeding that is most probably less than the case with complete mole. But let me tell you that most of the cases are not suspected clinically prior to evacuation. In the ultrasounds, you might see those cystic changes. You might see a fetus, or no, sometimes even the fetus not there. It was lost in a way or another. Maybe not found in the ultrasound nor in the gross. What about the beta FCG? It's mildly elevated in most of the cases. Okay, so that's the pathogenesis. That's when we have two sperms fertilizing a single ovum or a single sperm that is duplicating, and at the end, this results in a triploidy that is 69XXY. We call this a diandric monogynic triploidy that occurs in 95% of cases, and this is dispermic in origin. So what do we have on the gross picture? We have this, okay, some sort of villas, but they are definitely less than that of the complete. Okay, we have the gestational sac. Sometimes you might have fetal parts. Okay, we might have intact fetus, but not all the time. And if we have this fetus, it may show gross restrictions or malformations. The syndactyly are actually the most common of which. What about the microscopic picture? The characteristic microscopic picture includes actually two population of villi, as I have told you, with variable degree of hydrops. Some of them are hydropic villi that are large and irregular. Some of them are small and fibrotic. They have this scalloped edges. You can see they look like this island, okay, and they may show cystine formation. I told you cystine is the pale area. They have trophoblastic inclusions. You know what are pseudo inclusions? That's when the trophoblasts enter into the inside of the villi, and then they have a transverse section. They appear like this. It's as if trophoblastic islands are inside the villi. Okay, what about the trophoblastic proliferation? There's definitely trophoblastic proliferation that is mild or moderate, near, yeah, a bit less than complete circumferential. Okay, we have the fetal RBCs. We can see some fetal RBCs, and we can see fetal blood vessels actually. Okay. What about the P57 IHC? If we do P57, it will definitely be intact in the cytotrophoblasts, the one at the periphery, and the villus stromal cells inside, because in this case we have both paternal and maternal genetics. Okay, what about the diagnostic molecular testing? This actually gives a precise diagnosis when we have a diandric triploidy. The differential diagnosis includes the partial mole, the complete mole, the hydropic abortus, the trisomies. trisomies come in the differential diagnosis, and the twins. There is one more thing that I have mentioned while talking about the complete mole. If you have a twin gestation with complete mole and coexisting fetus, and now I can tell you how we're going to differentiate using the P57. In a case of fetus, I will have actually in the immunohistochemistry two sets of villi, some of which would have the P57 intact and the others would be lost. The ones with the loss of the complete mole and the ones with the intact are the ones of the fetus, the other twin. But if this was a partial mole, the stain would have been intact in all of the villi. Okay, so both they have fetus and both they have vesicles, but the P57 can differentiate. Other differential diagnoses include placental mesenchymal dysplasia, digynec triploidy, and I told you about it at the beginning when we were talking about the pregnancy scenarios. And again, this will be differentiated using ploidy analysis, maybe, etc. Okay, so to wrap up things, what are the essential diagnostic criteria? We have characteristic morphological features, we have a diandric triploidy, and according to WHO, actually, the definitive diagnosis requires molecular analysis. What's really desirable is to see a retained P53 IHC to exclude the complete mole. As for the prognosis, it's definitely better than that of the complete mole, as we have like a half to 5% only persistent GTD, less than 0.5%, and in some publications 0.1% are transforming into choriocarcinoma, 0.28 with risk of recurrence. Okay, now we go for the third case. Case number 3, we have a 41-year-old woman presented 2 months after curettage of molar pregnancy with vaginal bleeding and acute abdomen. So you had this case, and she had the molar pregnancy, and she had the curettage, and everything was okay 2 months ago, but now unfortunately she's having the bleeding and the acute abdomen. She had her beta HCG, there's persistent high HCG levels, and this is her ultrasound. So what are you thinking of? Yes, this is a persistent mole. A persistent mole actually is defined when there's remaining molar tissue after original treatment, usually medication or curettage, with a persistently elevated serum HCG. And it's one of case scenarios. It's either there's an invasive hydatidiform mole where there's invasion of myometrium in the uterine vessels, or there's metastatic mole where chorionic villi are in sites beyond the uterine cavity, most commonly the vaginal wall or the pelvis. These cases are actually treated with chemotherapy, of course, in absence of complications. And this probably occurs with complete moles more than partial moles. Okay, now we go for the second topic, which is the abnormal non-molar villus lesions. I don't want to take lots of time in this actually, but I would love only to shed the light on the fact that we have this entity. We have cases where there's abnormal villus lesions actually, but these are not molar pregnancies. These cases are biparental diploidy, and they include the hydropic abortions, some various chromosomal alterations in trisomies like 18 and 21, the digynec monoandric triploid I told you about, placenta mesenchymal dysplasia. All these actually, they simulate the partial mole in their features, and they have P57 impact. So how are we going to differentiate between these and the partial mole? We need actually molecular pathology, DNA genotyping, to differentiate between them. Okay, the third class that we'll be talking about today is the tumor-like trophoblastic lesions. These are actually bland lesions. We have two, the exaggerated placental site and the placental site nodule and plaque. The exaggerated placental site, those cases are actually, most of which are asymptomatic and may present with vaginal bleeding. And most important of which actually is that they are non-mass forming, so we do not have a mass, but under the microscope they are infiltrative in nature. This is actually physiologic and it regresses spontaneously. If you do the key 67, it's slow. There's almost no mitosis, but there is an unusually striking proliferation and atypia. Okay, so don't be scared when you see this. It is originating from the implantation site, intermediate trophoblasts, and this is an important thing. And they occur necessarily after recent pregnancy. So take care if there's no recent pregnancy history, and if there is a mass, if there is destructive invasion, if the Ki67 is more than 10%, you have to consider what? You have to consider the placental site trophoblastic tumor. So take care. Okay, well, you can see this in uterus, fallopian tube, or barely X-ray uterine gestation site. What about the placenta site nodule or the plaque? That's again an incidental finding that may be associated with vaginal bleeding, but no HCG elevation. Again, it's a benign one, okay, and it's an incidental and occurs in reproductive age after pregnancy, but the interval this time might be years, okay. Grossly, it's well circumscribed, but usually the size less than 5 millimeter. On the microscopic level, it's originating from the chorionic tribe intermediate trophoblastic. This is again an important thing to bear in mind. It's characterized by the presence of an abundant eosinophilic hyalinized matrix. So what about the IHC? They give positive with the cytokeratin, the P63, GATA3, and inhibin. And again, this is important. It has a low Ki67. They have a low proliferation power. Okay, another NB or take care because there is something that is called the atypical placenta site nodule. That's actually a trending entity, or better say, an imaging entity that describes the lesions when they have larger size, they're more cellular, they have more atypin, they have mitosis. And what's the importance of these? The clinical importance is that they are considered as precursors to epithelioid trophoblastic tumor, and this is another GTM. Okay, now let's go to the GTN, the main course for today. Actually, gestational trophoblastic neoplasms are four types. We have the gestational choriocarcinoma, the epithelioid trophoblastic tumors, the placental site, the trophoblastic tumors, and finally the mixed trophoblastic tumors. So let's go to the next case. We have case 44. Case 4, we have a 33-year-old woman presented with vaginal bleeding and hemoptysis. In other case scenarios, she might be presenting with vaginal bleeding and increased intracranial tension. She might be complaining of just increased intracranial tension. In this case, she might go to you, her gynecologist, her obstetrician, or she might go to the chest physician. She might go to the neurosurgeon. You can spot her in different clinics. Okay, so this patient has vaginal bleeding, markedly elevated HCG. Her ultrasound and Doppler, as you can see, there's this mass filling the uterine cavity, and it's highly vascular. As you can see, her chest X-ray has those two placental nodules, and this CT with those nodules. One, we have this microscopic picture of a malignant tumor that is invading and infiltrating with vascular pools or channels that you can see. Vascular pools, better say. We have the HCG immunohistochemical stain, and it's diffusely positive. So what are we supposed to be thinking of? Yes, a gestational choriocarcinoma. So what's a gestational choriocarcinoma? That's actually a malignant tumor, the most common GTN. You can see in it by population, tripopulation of villus and tissue trophoblasts, cytotrophoblasts, and intermediate trophoblasts. That is seen in the uterus, or sometimes less commonly in ectopic or metastatic sites, because it's highly metastatic, as we will mention. It's seen in the reproductive age group. The patients are presenting with vaginal bleeding or hemorrhage at ectopic or metastatic sites with highly elevated levels of HCG. Okay, something noteworthy to be said, that there is some incidence of an intraplacental choriocarcinoma occurs. That occurs actually at any trimester, but commonly in the third trimester, and it's asymptomatic until there is metastasis within the patient, or rarely in the infant. Actually, haven't seen a case with infant medicine, but it is recognized in some publications. Okay, so what about the risk factors? We have the prior complete mole, advanced maternal age, and finally the race. What about the pathogenesis? It's estimated that 2 to 3% of complete moles and 0.5% of partial moles progress to choriocarcinoma, and the most of the choriocarcinomas are androgenetic XX. As I will tell you that like 50% of the choriocarcinomas are preceded by complete moles. Again, 25% are preceded by spontaneous or induced abortion, 22.5% are preceded by normal pregnancies, and 2.5% are preceded with ectopic pregnancies. So how do we see a choriocarcinoma grossly? It's single or multiple dark red masses. They used to tell us that the choriocarcinoma is like pools of blood, okay? We see florid hemorrhage and necrosis. Deep mitral invasion might be noted with a uterine perforation. That's a picture of an intraplacental choriocarcinoma. That's the placenta and that's the cord, okay? But let me tell you one thing, that the intraplacental choriocarcinoma may look inconspicuous macroscopically. It may mimic a placental infarct or thrombus. So please, if you please, for all the obstetricians, examine the placenta very well. And if there's anything that is query or that is worrying you, just send it for pathology. And there they have to do some thorough examination within 5 millimeter interval sections and see what's there. Sometimes they look like papillary to solid lesions and appear like this. Okay, so what about the microscopic picture? We have this infiltrative destructive solid aggregates of situs in situ and intermediate trophoblasts. Actually, they used to call it a bipopulation or a triple population. Okay, we have a marked atypia, we have hemorrhage and necrosis. You can see all these blood lakes. They actually explain maybe why choriocarcinoma has very high tendency to metastasize. It's really characterized by hemorrhage and necrosis, lymphovascular permeation. That's the real reason for the metastasis, let me tell you. And we do not have any chorionic villi. Except for one instance, that's when we have an intraplacental carcinoma, choriocarcinoma, then we have this transition between the benign villi and the malignant villi uh, side by side. Okay, so what about the IHC? We have actually a long panel, but the most famous of which is the strong immunoreactivity of the HCG and the SAL4. Those two markers are actually trophoblastic markers and they are positive. In choriocarcinomas, cytokeratins would give positivity. What's really important is the Ki67 giving a typically high nuclear positivity. Differential diagnoses include the other GTNs, include the non-gestational choriocarcinoma of germ cell origin, include somatic carcinoma with trophoblastic differentiation, and includes the other benign lesions and precursor lesions that we have just mentioned. So let me remind you that we have a non-gestational choriocarcinoma, and we all know that the gestational choriocarcinoma is actually the one that is chemosensitive, way more chemosensitive. But the bad news is that they actually both look under the microscope typical and immunohistochemistry typical. The real differentiation is actually clinical within the including the age differentiation and the site where each tumor arises. Would be very unlucky if you had that gestational choriocarcinoma maybe in the ovarian metastasizing to the uterus, maybe in the CNS and metastasizing to the uterus. Then we will have to go to genotyping because the gestational ones show unique paternal alleles of the index gestation in a big number of cases actually. As for somatic carcinomas with trophoblastic differentiation, I believe the IHC would be of value. The HCG would show positivity in scattered cells, and there would be histologic differentiation to the other population of carcinoma. So to wrap things up, according to the WHO, we have essential diagnostic criteria and desirable diagnostic criteria. The essential including the characteristic biphasic pattern of the mononuclear malignant villus cyto and intermediate trophoblasts against the random multinucleated syncytial trophoblasts. Okay, we have desirable the IHC that helps when the classic pattern is lacking in the genotyping if available that can be supportive. And you all know better than me how the chemotherapy gives excellent response and very high cure rates, and this relates actually to the tumor stage and prognostic score. Dr. Ahmed has talked last time about the WHO scoring system and how it plays an important role in determining the chemotherapy for sure. In some cases, surgery may be indicated when these cases have maybe uncontrollable bleeding or chemo resistant or something like this. Okay. Now we go for case number 6. Case number 6, we have a 36-year-old gravida 1, para 1 woman with prolonged menstrual period and increased volume, thickened endometrium, uterine cavity mass in hysteroscopy. Okay, so she had a menstrual bleeding, and this is actually what you have seen on an examination on her hysteroscope. Okay, the beta HCG was actually less than 2500 MIU per milli, and we had this biopsy, then a decision for hysterectomy because we had this tumor that you can see within epithelioid-like cells that show moderate atypia and distinct cell borders and a positivity in the P63 and a well-recognized Ki67. So what are you thinking of? What might this be actually? Yes, an epithelioid trophoblastic tumor. So again, according to the European Organization of Treatment of Trophoblastic Diseases, there are those minimal requirements, and including the biopsies and the imaging and the staging, these best practice that are referring to the GTD center. I'll be talking about this at the end of the talk actually. Okay, so what's the epithelioid trophoblastic tumors? Again, that's a malignant tumor, one of the GTNs, but it's the rarest GTNs. It arises from chorionic type intermediate trophoblasts. Do you still remember that? Okay, maybe seen in the uterus, the lower uterine cervix, the tubes, the ovaries, and the peritoneum. It's mostly presented with vaginal bleeding with mild to moderate HCG elevation. What's noteworthy is that it has a precursor lesion. Remember the atypical placental site nodule, that's a precursor lesion for ETT. Grossly, it appears as an invasive discrete nodules or cystic hemorrhagic masses with a cut section that is whitish to tan, may show hemorrhage and necrosis. This tumor is characterized by ulceration and a fistula formation and deep invasion that may result in a fistula formation. And microscopically, this is how it looks like. It's almost well circumscribed and nodular. The trophoblasts are medium sized, as you can see, in the form of cords, nestor masses. The cells are more or less uniform with the moderate amount of granular eosinophilic cytoplasm. The atypia is actually moderate, the mitosis is variable. We have extensive geographic necrosis. We have eosinophilic material that is characteristic at the center of the tumor nests and in between the cells. What about the IHC? It takes P63. There's actually again a panel. Those ones are for the trophoblastic markers, but the P63 is characteristically positive nuclear. As you can see, cytokeratin 5/6 would give positivity as well. Its Ki67 is high. It's more than 10%. If you give her a sulfur, it would give a negative result for which. Again, this is another image showing the positive P63 and the Ki67 that is more than 10%. So to wrap things up, according to the WHO, we need the epithelioid trophoblastic intermediate trophoblasts that gave a P63 positive, those ones, the chorionic with a nodular lesion, and the Ki67 that's more than 10%. What about the prognosis? We have 25 to 30% metastasizing, 10 to 24% are fatal. Worst prognosis when we have a high mitotic count in the 4 years since antecedent pregnancies. Those tumors were found to express PDL1. That's giving some hope for trials or for cases that are responding to immune checkpoint inhibitors, maybe. Okay. We go for the last case. That is case number 7. We have a 32-year-old female with amenorrhea and uterine enlargement. Her HCG level was 700. That's mild elevation. Her ultrasound shows a diffuse heterogeneous myometrial echo texture and hematometra distending the endometrial cavity with an irregular contour of endometrial cavity in the fundus region. That was the tumor grossly, and that was the tumor microscopic. You can see it has the atypia that is high this time. Okay, we had the IHC, immunohistochemistry. We had the HCG was focally positive, so this is again is the choriocarcinoma. We had a P63 negative, so this is again is an epithelioid trophoblastic tumor, but we have an HPL that was diffusely positive, so this goes with, what do you think? Yes, a placental site trophoblastic tumor, a placental site trophoblastic tumor. So, what's placental site trophoblastic tumor? That's again a malignant tumor. That's it's like 4 to 5% of the GTN. They originate from implantation site intermediate trophoblasts, and that's important that we relied on in IHC. We can see it in the uterine corpus there or the extrauterine. Most of the cases are complaining of history of missed abortion, amenorrhea, some with vaginal bleeding, uterine enlargement, and abdominal pain. Rare cases are seen with virilization, nephrotic syndrome, and erythrocytosis. Their HCG is mild to moderate. They have elevated HPL in the serum, by the way. Most of them are presented early within a FIGO stage 1. So grossly, we have a tumor that is almost well circumscribed and nodular, that's invading the endomyometrium and involving both with a tan to light yellow cut section. Deep myometrium invasion occurs in 50%, may reach up to perforation, and hemorrhage and necrosis for sure are seen. As you can see under the microscope, this tumor is infiltrative tumor showing nest sheets and aggregates with large polyhedral or round mononucleated cells. We can see scattered multinucleated cells and abundant amphiphilic, eosinophilic, or clear cytoplasm. The ATP is marked. You can spot it here easily, okay? When this is the necrosis can be seen. Vascular invasion again is seen, and typical myometrial infiltration is detected. So again, we have a panel, but the most characteristic of which is the HPL with the MELCAM positivity. The Ki67 is usually expressed higher than 10%. We have negative stains with P63 excluding the epithelioid trophoblastic tumor, focal HCG or negative excluding choriocarcinomas, and the SAL4 as well. So the diagnostic criteria according to WHO, we have an invasive trophoblastic neoplasm with compatible immunoprofile. For those cases, simple hysterectomy is curative. We have 25 to 30% may develop recurrence or mets, 6.7 to 27% mortality rate. So one more question. Can I see a mixture of 2 or 3 of these, the choreo, the placental, or the epithelioid? Yes, we can see. So what do we call this afterwards? We call it a mixed trophoblastic tumor. Okay, and this is the IHC that I have mentioned, differentiating the different GTNs and their differential diagnoses, as you can see. There's one thing that I want to mention, that is the trophogram, if you have heard of. So what's the trophogram? Actually, that's an immunohistochemical algorithm for GTD proposed by Dr. Leming Shi in 2007. Putting forward a number of IHC immunohistochemical stains that we can use in a stepwise fashion to reach the diagnosis of the GTN. So he proposes the usage of the low molecular weight cytokeratin together with the HSD3B1, which is a trophoblastic marker, and it says if we have those both are positive, strong, and diffuse, then we have trophoblasts. If you have the cytokeratin is only the positive one, so we have a non-trophoblastic epithelial lesion. Okay, having trophoblasts, we can go for beta HCG and see if it's positive and we have a mixed population, then this is choriocarcinoma. We can go for the P63 and the HPL. If we have a negative P63 and HPL, that is really positive, diffusely positive, then we have an implantation site intermediate trophoblast related lesion. On the other hand, if we have a P63 that is strong and diffuse positive and HPL that is focal or negative, then this is a chorionic type intermediate trophoblast related lesion. So what we do afterwards, we go for the Ki67. As for the implantation site intermediate trophoblasty, the Ki is less than 1%, so this is probably an exaggerated placental site. If it's more than 10%, then this is a placental site trophoblastic tumor. What about the chorionic type intermediate trophoblasts? If we have less than 8% Ki67 together with preferably cyclin E negative staining, then we have a placenta-site nodulum plaque. If we have a Ki67 that is more than 12% with a preferably cyclin E positivity, then this is an epithelioid trophoblastic tumor. Then we have some more remarks to shed the light on. That's the FIGO staging. in the FIGO staging, we have those 4 stages. The stage 1 when the tumor is confined to the uterus. Stage 2 when the gestation trophoblastic tumor extend outside the uterus but still limited to the genital structures. The stage 3 when the trophoblastic tumor extends to the lungs with or without known genital tract involvement. And the 4 that includes all the the other metastatic sites. I know that the OB gynecologists, they always prefer the FIGO staging, but some pathologists go for the TNM. That's the one for the American Joint Cancer Committee. So if we opt for the TNM in GTNs, we have only T and M. We do not have an N. So the T1 when the tumor is confined to the uterus, and the T2 when the tumor extends to other genital structures, including the ovaries, tube, vagina, broad ligaments, by mets or direct extension. What about the M? The M1A is the lung mets, and the M1B includes all other distant metastases. Okay, that's the WHO scoring system based on prognostic factors modified as a FIGO score. Okay, and that's the how it is interpreted. I believe Dr. Ahmed has been so deeply into this in the previous lecture. So let's move to the last part of our talk today, and actually it is the fact that the ESGO supports the European Organization for Treatment of Trophoblastic Disease. I had to mention this as you are now an ESGO accredited center. So your ESGO supports this group that has become a special task force under the ESGO umbrella focused on topics related to trophoblastic diseases. So the EOTTD actually had a very nice publication in the 2020 addressing the treatment and referral of gestational trophoblastic diseases. What actually caught my attention was the proposal at the end of this paper talking about the establishment of a national GTD center. They're calling for the importance of establishing for such a center everywhere because they believe that the centralized care is needed for optimal management of a rare disease like GTD, and that without some type of centralization, treatment decisions will be inconsistent. So I'm coming today and proposing the first step actually, and I will be leaving the next of the steps for Dr. Basel to do them and to call me maybe, okay? So the step number one is sharing the idea and promoting for it, and this is what I'm doing for now. The step number two is find support from the National OBGYN governing body. The step number three is to set an MD team from gynecologists, gynecological and medical oncologists, oncology surgeons, pathologists, nurses, HCG laboratories. Number four is to create or adopt clinical guidelines, create a database, develop a website, and make sure you're using a proper HDSA system. You have to look for annual funding, and finally go and find a connection with the international societies like the International Society of the Trophoblastic Diseases and the European Organization of the Treatment of Trophoblastic Diseases. Now I come to the end of my talk. I always love to shed the light on the importance of multidisciplinary teamwork. Yeah, I'm so happy and so glad I'm with you tonight. These were actually my references. This is my YouTube channel, my Facebook, and my social media. You can, I'm inviting you to join me for Pathology from the Scratch group. Thank you so much, everyone, for your attendance, and thank you for listening. Thank you so much, Dr. Bissett. It was actually my honor joining you tonight.
Thank you so much, Dina. Really, it was a very interesting talk. By the way, we have a GTN clinic here in Mansour University, not in our center, but in the OB-GYN department, which was created by Prof. Reda Shouki. He is one of the GTN pioneers all over Egypt, whom we all sent our condolences because he have just lost his daughter last night. So our deep condolences for him. But really, we have a GTT center in Mansoura, OB-GYN department, that they are doing centralization of care, and they are doing a very good job there. Thank you, everyone.